Hello, everyone. It's Joyce Troxler from ETSU BMAT ECHO. My background is family medicine and addiction medicine, and I'm here to facilitate this second to last session of BMAT ECHO. Last session will be July 7th, and we're looking forward to today's presentation and looking for a case for today, because we do not have a preloaded case. So if you guys have anything that you've seen, heard, want to bring back from past cases, that would all be awesome and wonderful. So we have a case to talk about today. So be thinking about that as we're going through our presentation. And then on the 7th of July, that is our last session, we will be taking a short break, maybe a few weeks, month and a half, something like that. We'll take a break and then come back with another round of all these wonderful case presentations and didactic sessions to share with everyone who joins us regularly, and bring some friends with you, and continue to grow ECHO and the impact that we have on our community and appropriate evidence-based care for patients with substance use disorder. But when we come back from our break, we will be coming back with a new name. We will no longer be BMAT ECHO, because I feel like that's a little too narrow of a name for what we do. So we're coming back as I Am ECHO. So be looking for anything I Am ECHO, which stands for IAM, Integrated Addiction Medicine ECHO, because that's really what we're doing. We have integrated team members, and we are having people who participate from many different realms that work with and touch the lives of patients who have substance use disorder. So name change when we come back in our next series. So just keep an eye out for that. I'm going to go ahead and ask everyone else to do introductions, and I will start with Brian Clark, please.
I'm Brian Clark. I am the technology coordinator for ETSU CME. If you have any technology issues on this session, please send me a chat or call the number on your screen.
Thank you so much, Brian. Mina, if you can unmute and introduce, please.
Hi, I'm Mina McVeigh. I'm a licensed clinical social worker, and I work in the addiction medicine clinic here at ETSU.
Wonderful. Thank you, Mina. Mina will be presenting today for us. Melissa, if you can unmute and introduce.
Hi, I'm Melissa Hitt. I'm the educational planner for this program. And I do just want to make a note just to say this, that complete your evaluations. We do use those as feedback to plan for the upcoming series starting in August. And also another thing to be looking forward to in August is that we do have some additional credits that will be offered. So be looking forward to that as well.
Awesome. Thank you, Melissa. Meredith, if you can unmute and introduce, please.
Hi, my name is Meredith Ginley, and I'm a clinical psychologist and an assistant professor in the Department of Psychology at ETSU.
Fabulous. And today we're doing that great thing where we have integrated presentation. So Meredith will be presenting with Mina. Michael, if you can unmute and introduce, please.
I'm Michael Michigan. I'm a psychologist and a behavioral health. Clinical director for behavioral health operations at TenCare.
Wonderful. It's good to have you with us again, Michael. Katie, if you can unmute and introduce, please.
Psychiatric nurse practitioner program.
Great. We didn't hear all of that, Katie, so there may be a volume thing going on your end, but it's good to have you from our nurse practitioner program. We heard that last part. It's good to see you. Rick, if you can unmute and introduce, please.
Hey everybody, I'm Rick Wallace, and I'm a librarian at the College of Medicine at ETSU.
Wonderful to have you with us again, Rick. Thank you. Sudha, if you can unmute and introduce, please.
Hi everyone, my name is Sudha Kumar and I'm a nurse practitioner resident.
Wonderful, it's good to see you, Sudha. Thank you for being here. And Hefner, I'm going to try and remember her first name. Is it Keith or is it Kevin?
Yeah, it's Keith Hefner, behavioral health case manager.
Hi, it's wonderful to have you with us, Keith. Thank you for joining. Simona, if you can introduce, I think you're already unmuted.
Hi everyone, I'm Simona. I'm one of the addiction medicine fellows at ETSU.
Wonderful, it's good to have you with us, Simona. All right, without further ado, I'm going to go ahead and turn it over to Mina and Meredith, and they can start their presentation. Oh, 1 second, because I'm looking at tiles and forgetting I'm in a room with other people. Only because lunch is being eaten did I realize I'm with other people. Hold up. Sorry.
Hey there. Cameron Heil, I'm a psychiatrist, addictionologist, working in family medicine, addiction medicine fellowship.
Wonderful. Thank you, Cameron. And I apologize. If you hadn't been eating lunch, I would have just been cruising looking at this screen.
I know.
And then I can't make it go any further, but I've got one more.
Hi, I'm Richard Rhodes. I'm a visiting internal medicine resident here, rotating through the fellowship.
Thank you guys so much. Should have been throwing things at my head to get my attention so I could introduce you. All right, now without further ado, Meredith and Mina, it's all you.
Meredith, are you going to get us started?
I can, sure. So yeah, so we're going to be talking today about engaging family in your primary care, medication-assisted treatment patient's treatment plan. And we have no disclosures. And then Mina's going to start us off.
Okay, so the objectives for our program today are first to use some cultural humility to define what we mean by family. We're going to provide some evidence supporting family versus individual counseling. We're going to discuss how to assess family support. We're going to help you recognize the difference between helpful and hurtful support. Going to highlight some in-office family work that a behavioral health consultant might be able to do on a team. And then we're going to present some referral options for treatment. Next slide. Okay, so first, I want to spend just a brief moment defining family and reminding everyone what cultural humility is. We used to talk about cultural diversity, and then we talked about cultural competence, but the word that is coming to the fore today is cultural humility, which is the ability to maintain an interpersonal stance that is other-oriented, as in open to other person's cultural identity with things that are important to them. And so we're going to define family for you as the patient would define the family. It's up to them. We don't really have any existing ideas of what a family might look like. It might be a spouse, it might be a partner, it might be a roommate, it might be a mother, a grandmother, a sister, a brother. It might be an LGBTQ family system. None of the above, all of the above. So just remembering that we're going to use the term family, but we use that broadly. Next slide. So why is it important to engage family and friends? So here's a little research for you. I hope that this will motivate you to begin including family systems in your work. We know that high emotional expression, which is emotional over-involvement, overt criticism, hostility, and some other things by family members. We know that that when a person lives in that environment, that they're 3 to 5 times more likely to relapse than those who are living in a healthy or a low emotional expression environment. Interpersonal conflict is the second highest cause of relapse in substance use disorder, and that's from the Watts article as well. So it would behoove us to include interventions that help to manage interpersonal conflict if it's a significant cause of a return to use. Relational and social stability is more predictive of long-term treatment gains than the severity or chronicity of a substance use disorder. And interesting, 32% of clients in this study by Fall Stewart who entered treatment met inclusion criteria for couples therapy. So they're already coming to treatment needing couples therapy. So next slide. Also, the research shows that behavioral couples therapy, or what we call BCT, produces greater overall abstinence and better relationship functioning than individual-based treatment. So who knew? We do a lot of individual-based treatment, but we would be better served if we would do couples therapy. In fact, brief behavioral couples therapy, which is just 6 sessions plus individual therapy in this study, is just as effective while being more cost efficient as longer treatment behavioral therapy. In a study that looked just at women receiving behavioral therapy, in addition to their individual therapy. They had few substance-related problems than if they were to get individual therapy alone. And one that I know will touch Dr. Troxler's heart, behavioral therapy decreased the symptoms of children in this study of alcohol use disorder, whose fathers had alcohol use disorder, on a pediatric symptom checklist. And so there was this significant decrease in the percentage of children that were surpassing the cutoff score for pediatric behavioral problems, mental health problems. So we treat the couple in this study of fathers with alcohol use disorder. We bring in their partner, and the children get better, in addition to all the other improvements in the couple system and in the individual who's receiving treatment. So I hope that will motivate you to look to take a deeper look at family therapy. Next slide. Okay, Meredith.
All right, so I'm going to talk a little bit of assessment of family support, and there's some like structured measures available, looking at like social support or a little bit, some on like specifically on family support. But Mina and I were discussing this, and we both do this a little bit more informally partially because the measures are pretty narrow. It's kind of like people you live with, and it doesn't really capture what families can look like. And then it also it's a really good conversation to have, because you can get a lot of insight into the kind of the system and kind of the things that are helpful, potentially helpful to the patient. All right, so the kind of the conversation that we have tend to be around trying to figure out and try to understand if the family members, that kind of that broad definition of family, if they're going to be helpful to the treatment process or they're going to potentially be hurtful to the treatment process. And this is an ongoing assessment, is kind of another important part of this, because how things look at the beginning of treatment tend to change over the course of time. Because when you change one person within a system, the whole system changes and has to respond and react. And people that they're interacting with on their daily basis, their family, can change, and they can become more helpful or less helpful as the patient becomes moves towards abstinence or sobriety. So things that are helpful in the that I hear, that I get excited about, that I hear, is when family members are really hopeful and the family members themselves have a lot of resiliency. So they're willing to say, okay, like this has gone bad 6 times before, but I'm going to be really hopeful this time. And I'm going to treat it like I'm going to have a short memory, and I'm going to forget everything that happened before. And I'm going to hope that this time's going to work. And I'm going to go all in and be right there with this process. Low stigma around medication-assisted treatment is also really important. If the family doesn't understand medication-assisted treatment and thinks it's, the patient is just swapping out one drug for another, that can be damaging to long-term care retention. And then the family dynamics are going to change. So when a person in recovery, they often can become more present within the family because they're not spending as much time in their use and in their activities that they required to engage in order to maintain their use. They're home, like they're there to help take care of kids. They're there to do dishes. They're there to help with the grocery shopping. And that is a big shift in a family. It's like someone coming back, they've been traveling for months and months, and now they come back and they're home, and now they're like in your house, and what do you do with them? And we're hopeful that families are going to be excited about that. And they're like, yes, like now you're home to help. Yes, you're home to, be with our kids. And then also family members that are willing to engage in some amount of accountability. So not wanting, not kind of just giving more examples of ways the patient can, bailing the patient out. So if, the patient doesn't show up for their appointment, and I call and the family member says, oh yeah, they had a job interview. And then the next time I see the patient, that wasn't true. Wanting patients, families that are going to hold the patients accountable and be part of the process towards recovery. Things that are less helpful, things that are kind of red flags, and that maybe during the assessment process, I'm going to keep watching for, is when I hear continued substance use within the family. a lot of that high expressed emotion that Mina talked about on the earlier slide, that family dynamic that's really highly conflictual. Because family conflict and then negative emotional states is the other big reason for relapse. So a lot of times why the people that get us the most upset are our family members. And then families sometimes get resentment around being left behind. You know, this person is spending all of this time getting their appointments, you know, they're spending all their time going to meetings, they're not spending time on us, or they are shifting dynamic. Like now you're here and you're trying to take care of these kids and you're telling me what to do and you've never been here before. Like there's pushback there. So that family has to grow and shift with the additional presence. So hearing about that and willingness to change versus resentment that's coming up. So we're going to talk, our next kind of batch is about interventions that we can do. In general, family therapy process research is going to be kind of guided by this general idea that having the families present is going to promote post-treatment protective factors and help maintain those good outcomes. So that's kind of all of the interventions are very much around the kind of thinking like now, but also towards the future, and that the family is going to be kind of the therapists that are there in the future after traditional therapy has ended. So Mina's going to talk next about interventions that a behavioral health provider could provide directly within your clinic. And then I'm going to wrap up with some options about referral if you don't have behavioral health in your clinic.
All right, thank you, Meredith. So I practice brief interventions in our office here, but I also do some more traditional 15-minute interventions. But I'm going to focus on what you might be able to do with a behavioral health consultant on an interprofessional team. And so always, and let me take a step back. All of these interventions are interventions that alone have been proven to be helpful. As well as together, behavioral couples therapy itself uses a lot of different interventions that can be kind of teased out and maybe done one at a time. There is no research on that. So if anyone wants to do some research about using a brief family therapy in MAT, then call me up. Maybe we can work something out because there really isn't anything on that right now that I could find. Of course, Rick Wallace always finds things that I don't find. So Rick, if you're listening, let me know. So psychoeducation. So that is just talking to your patient and a family member that they might bring in with them to their appointment about substance use disorder, about medication-assisted treatment, about what it's like to live with a family member who has substance use disorder or is in recovery. And that can be a conversation, or it can be that you can provide them with printed material. One book that I have put in the reference list that I really like and recommend to family members of people who have substance use disorder is called Getting Your Loved One Sober Without Nagging, Pleading, and Begging. It follows the CRAFT model, which I think Meredith may speak a little bit about. And it's it's easy read, and you could recommend it to your patients and their family members. So psychoeducation is always good. I would say the majority of patients do not bring in a family member on their first session. You could talk to your patients about what the research shows about selecting a family member to be involved in their treatment. That would be a good thing to do. Another thing that you can do that doesn't take much time is enlist the help of a family member in medication adherence. And an example of this would be supervised disulfiram. So basically giving someone in the family permission, the patient would, to hold them accountable by giving them that medication every day, since that medication has to be taken every day for it to be effective, or about every day. We've had patients in our clinic agree to let a family member dispense their buprenorphine so that they don't overuse it. That can be, in some cases, that's a parent or a partner. So that's a very easy thing to do to involve a family member. Contingency management. This is used within behavioral couples therapy, but you can do this as a standalone, which is to invite a family member to reward the patient when they meet their recovery goals or their treatment goals. the best way for this to work is for the patient to agree to an activity that they would enjoy doing with the family. And that if they meet their goals, then the family member will do that with them. So it might be, if you meet your goals this week, we'll go out to dinner. Contingency management can be used without the family as well. But in this case, I'm talking about using the family member to reward the patient with an activity of their choosing. So motivational interviewing is always a good thing. Things that you could use that for would be to motivate the patient to invite a family member into treatment. So just having them imagine how that might be helpful, and using motivational interviewing techniques to get the family member involved. So that's an example of how you might use that. And there's many others. Behavioral couples therapy. So this is the therapy that a lot of the research that I cited, that's the type of therapy that they were doing. It's a behavioral therapy that was designed for substance use disorder. And the things that it involves can be teased out and done briefly in office. One of those is just the recovery contract, and that might include a medication adherence contract. It might include other behaviors, but you basically get the patient and their family member to agree to things that the patient is going to do within a time frame, and those would be SMART goals, of course. And then you would hold them accountable and using some reward or something else. So recovery contracting. Assertive communication skills. You can teach how to use iMessages in 5 to 10 minutes. And in behavioral couples therapy, that's going to obviously take a little bit longer, but I oftentimes will just go in when I know there's a conflict in the family and teach the patient how to talk to their family in an assertive versus an aggressive way. That's just a basic coping skill. Conflict resolution together with problem solving strategy is also part of behavioral couples therapy, but can be done as a standalone. Problem solving strategy or brief problem solving strategy, there's been a lot of research on that, is identifying a problem, brainstorming solutions, selecting a strategy, and then evaluating it. So you can do that from one session to the next. Oftentimes, people don't even know how to verbalize what's going wrong. So if you have a patient and their family member, just talking about or identifying what the problem is can be very helpful to the couple. So next slide. Adult child and parent therapy, or parent to child therapy. I love both of these. So adult child parent therapy is that patient that is an adult but is currently living with their parent, and that happens a lot in substance use disorder. And so I will invite the patient to bring their parent who they live with in for a therapy session. And we work on some of the same things that we do in a couples session, which is assertive communication, conflict resolution, and problem solving. I've had a lot of luck with that, especially in just clearing the air. And so one of my favorite things to do. Second, I've been doing a lot of parent-child therapy, which is a parent has a child who's acting out because of past parenting deficiencies. And, you know, when you're struggling with substance use disorder, you're not in your very best parent mode. So the children do have problems. So I'll invite the child in, and we talk about what's going on. I will suggest some parenting skills, get buy-in from the child, and then they'll come up with a behavioral a solution that they go off and then practice and then come back and report. 9, 10-year-olds, 8, 9, 10-year-olds, it really doesn't take any specialized child therapy skills to do that. I'm not a child therapist, but when they get towards adolescence, you can begin to use some of these other skills to work with them. And if you remember the research that shows that if you do engage the family in therapy, the children get better. So thank you. Meredith, I think that's all I have there.
Thanks, Mina. So I have just a few slides just talking about so Mina is working within their ETSU's family medicine, addiction medicine clinic, and she can do all this stuff just right. You can just walk your patients over to her and she can take care of this for you. If you're not set up in a system that works like that, you're gonna be looking for names of things that you could say like, okay, let me Google this and find someone that does this. So here's a list of the names of the things that you're looking for. So there's kind of two groups of interventions. So this slide is for interventions that work with the target patient with a substance use disorder and those concerned significant others, those other family members. So kind of everyone goes into therapy together and all work. And there's often kind of some standards across these. There's that psychoeducation around use of medication-assisted treatment, the patterns of addiction, that type of thing. We also can refer concerned significant family members to get training to use naloxone, if that's something that your clinic doesn't directly provide training in. That's always a great step to be able to try to help save lives. These treatments in general kind of have main components around trying to help the families kind of improve motivation in the target patient, identify triggers, manage relapse, and then usually there's that reward component. So having the families reward behaviors that are in line with recovery and kind of ignore or not reward non-recovery related behaviors. The multi-systemic and multi-dimensional family therapies are usually more kid-focused approaches, but the rest of these are can be anybody, any families. And I've got some resources on the slides at the end with websites for each of these, but also just if you're Googling things in the area and seeing if someone offers these interventions, these are kind of the names of things. The other big group of interventions that you could refer family members to is these are interventions for the individual family members. This is if you have maybe someone that calls you, and I get this sometimes, is that someone will call me and they'll say, my family member has no interest in changing their behavior, but can I come into your treatment? Can I come get treatment at your substance use setting to be able to figure out how to get them into treatment? And can't really exactly do that. I can't make people that aren't in the room change, but you can refer those people to individual interventions that help them improve their own coping skills, change their own behaviors, change their own emotional reactions, even if that person in the family with a substance use disorder doesn't want to change. The idea here is that the family members themselves making positive changes, stopping arguing, stopping nagging, stop their engagement with the other in the angered way, working on maybe their own personal substance use or their ideas about substance use, that can change the system, right? And then that can make the person with the substance use disorder want to change. And then there's also, mutual support groups are great because they're free, but mutual support groups, Al-Anon, Nar-Anon, Alteen, similar kind of to the AA model, where there's steps kind of that people go through, but these are designed for the families, and the guidance is really coming from people who've been there and have had this experience before. Some of the key principles of these are accepting that you can't make the person with the substance use disorder change, not being so focused in on preoccupied with the person with the substance use disorder, and focus more of your attention, more of your energy on the people in your life that don't have substance use. So you're kind of just not always in that kind of sometimes chaotic spiral. Decreasing your own self-blame about why that person might have substance use, and moving towards forgiveness of that person with a substance use disorder, whether or not they change their behavior. So this can be really helpful for family members as well. And then I have 2 slides, and you guys will all have access to these slides, just with different resources Mina and I have found with finding groups or finding these treatments or finding more about these treatments. Let me just have a bunch of references.
And if you're interested, I included a lot of references there. If you want to look up some of these the studies on the efficacy of family therapy or behavioral couples therapy, I've included those. And I hope that one of your takeaways will be that family therapy should be seriously considered as on your treatment plan with your patients, and that there's evidence that for helpful family members, not now some helpful family members are not helpful, but that it can be more effective than individual treatment in improving the lives of our patients and increasing their days of abstinence, the social support that they do have. So I hope that I've inspired you. Joyce, I've been inspired, so we're going to have to change some things.
Perfect. That's what we want it to do. The more we know, the more we grow, and we get to make rhymes like that. But no, it's important that we stay current, we keep reading, we stay curious, and when we learn, we change and we adapt so we can be providing better care to our patients. Sometimes we just do what feels appropriate, and then we realize actually there's evidence behind it and we should have been doing it. And then when we are like, oh, there's evidence behind it, so let's get big with this and do it more. So thank you, guys. That was a fabulous presentation. It makes me feel really good about the work that we're doing here in our clinic. And I hope that we're encouraging all of you guys to do some of the same in your clinical settings as well. We've had another participant join us, and I'll get her to introduce herself. Veronica, if you can unmute and introduce, please.
Hi, sorry I'm late. I'm Veronica Ray, and I'm the Certified Peer Recovery Specialist and Bachelor's of Social Work here at ETSU Family Medicine.
Fabulous. Thank you, Veronica, for joining us. Other questions or thoughts for Mina or Meredith on this presentation? Other than it was fabulous, because it was. Thank you, guys. So this will be, Brian, are we still posting our recorded didactic sessions? Are they still going up?
Yes.
Okay, so because before we got started, we were noting that everyone on God's green earth, except for us, because we're here, and maybe some of you are on vacation and watching Echo, but everybody's on vacation. So we have a smaller crew than we normally do today because everybody's on vacation but us. So let them know that they missed out on a wonderful presentation from Mina and Meredith, and they can go to our webpage and or even just hit YouTube and search ETSU BMAT Echo and find the recordings from our past didactic sessions. This one will be included so they can watch it. I want people to hear what Meredith and Mina had to say today because it's important, useful work. Case-wise, who has a patient to talk about? I'm going to do the thing that they always did to us when we were in medical school or in residency training and turn to the person who's on the lower end of the totem pole. We've got a PGY2 resident working with us. Richard had introduced himself earlier. He's been rotating with us. This is his fourth week. He's getting ready to leave us, which I'm not happy about. I like to collect people, awesome people, and then I don't want to give them back to the rest of the world. Fellows included. Simona, I'm looking at you. So can you reflect on any of the patients you've seen in these past 4 weeks that you've got questions about or thoughts about? You can just kind of give a presentation on that patient.
Yeah.
Totally putting him on the spot. So he gets like extra special.
Not necessarily points from the past 4 weeks, but it's a buprenorphine patient that I saw in the hospital. She was admitted for some sort of skin or soft tissue infection from needle use. She was there for a few days, had a incision and drainage, and I saw her on the weekend, and it was time to discharge her, and her only home medication was buprenorphine. We asked her if she had any supply or any at home. She said that she did not, but had an appointment with her, whoever was prescribing it, later that week. We thought all was well, and then discharged her. And then about 10 or 12 hours later, she is in the emergency room after a heroin overdose. And my question for the group is, how do you think that we can improve that transition of care from inpatient to outpatient, specifically when it comes to making sure people are seen and get their medications that they need to prevent overdoses like that.
It's an incredibly important question. Does anybody have any clarifying questions for Richard? That was a very succinct presentation of a very important problem that we do see many of our patients deal with. So an admitted patient for a soft tissue skin infection treated with antibiotics. That could be a clarifying question. Got antibiotics. And then ready for discharge home, but does not have a bridging prescription to get from discharge to provider appointment. Shows back in less than 24 hours with an overdose.
I do have a clarifying question. Was there any kind of behavioral health or crisis team that came and spoke? I know she didn't come in for, she came in for something as far as her on her skin, but was there any kind of behavioral health that came and spoke with her at the hospital?
No, not unless there any sort of, thought of self-harm or suicide or homicide. That typically inpatient, that's a little, I guess, overlooked is a bad word, but not necessarily enforced or prioritized, unfortunately.
Okay, thank you.
Mm-hmm.
Other clarifying questions?
I have another one. So was there any discussion of, I know you said that to see if she had a prescription and the provider that was an issue, but was there any discussion about her substance use history?
It was very brief and rushed, and just to the point of, confirming that she did have that prescription and that she had follow-up at some point.
Okay.
But it was very brief.
Okay, thank you.
Michael,
Dr. Rhodes, do you know if the hospital has a social worker or social work department?
They do. There's actually several social workers, and that is typically not, I haven't seen too many, it's not typically what they're involved with. They do a lot of like nursing home placements and durable medical equipment, things like that. But as far as that domain, that I guess needs a little improvement or to be started, honestly.
Yeah, what I was thinking is it's similar to a nursing home placement, placing someone with substance use disorder into a treatment program might have been helpful.
Mm-hmm.
Michael, did you have a comment or question, or are you just fixing your monitor?
Just fixing my monitor, cutting down the glare.
Okay, good, because it looked like you were wanting to say something earlier, and then.
Oh, I appreciate that. Thanks.
You're welcome. You're welcome. All are encouraged here. Other clarifying questions? Do you have any, Cameron?
I have a comment,
Okay.
and I don't know if it's appropriate to be recorded. Well, I mean, I'm looking at it in this picture. I'm giving you another example. If you have a 6-line, highway, 3-line this side, 3-line the other side, and someone is blind and is crossing this highway, in the first 3-line, you go there and you jump in and you kind of, help that person to not getting any accident, but you leave them the rest of the highway to pass through and they get hit by the car. How do you feel about it? And this is the same thing that happens a lot in a hospital. We focus on the problem that they came in and we try to treat them. And we are doing a great job to do that, but we don't have any plan to prevent any bad outcome when they leave the hospital. And I mean, in this situation, if the patient was interested in the, medication assisted kind of the treatment, it would be possible for the provider to provide enough medication until the appointment comes and send the patient home with the instruction how to manage to have it, prevention for the return to use. But that didn't take place because that was not the case, looking at it as a treatment in general. It's just a problem focused approach was taking place in a hospital. And I think that that is one of those misunderstandings also among the providers, that if they don't have X number, they cannot provide this medication for the patient, which needs to be, more educated about it, that they may be able to give at least a daily dose of the medication and bring the patient every day and say, hey, this is a 1-day dose until your appointment. You can come here every day and get your medication until you see someone that is going to have a more approach to your substance use. That's my comment on this kind of case, but we don't know everything about what was going on in that facility, and we don't know what was the discussion took place. And the same way that you guys had a question, did we really focus on a substance use at the time that we were treating the infection disease? So we did not, most likely. So we need to approach that one. Bringing another, provider on board, it would be appropriate to ask for some, specialized person to come and talk about this substance use with the patient. If it was out of the scope of someone's practice, that to talk about it would be appropriate. So that would be my approach on this one.
Actually, Richard, do you know if the buprenorphine was continued while they were inpatient?
Yes.
It was? Okay. But as far as the ability to prescribe, to bridge from hospital to follow-up visit with their SUD provider, there wasn't anybody?
Wasn't refilled. It was continued on the medication list, but not refilled.
Okay, and is that because you don't have X-waiver providers in the hospital?
Mm-hmm.
Okay. But there is that, as Cameron was mentioning, the 3-day, it's a 3-day, 72 hours that they can come in and you can actually give it to them, and then they come back the next day and they come back the next day. I could have bridged them. Although in this case, I wonder the amount of time from discharge to return was pretty short.
Mm-hmm.
Do you know?
Richard, do you know if the patient was sent home with any Narcan?
No, she wasn't.
Mm-hmm. That might be something that could be standard of care is to check and see if a patient has Narcan.
Hmm.
And you can, like, we have it here for free, but you can also prescribe it.
Right.
We've kind of cruised into the comments, recommendations portion. Any other comments, thoughts, recommendations for Richard on this case?
I do. I have a comment, definitely. And again, I feel very passionately about this, and you don't have to have an X-waiver to show concern about somebody's substance abuse, and to know that it's there. And with personal experience, I was looked over many times because people weren't bold enough. Medical providers were not bold enough to practice outside. They don't need to practice outside, but they know they have connections, social workers, and that is the problem. Is that we have people that are too, I don't want to deal with that. That's too much. And it baffles me that somebody that is obviously in there for a problem directly from IV use will not be sent home with Narcan, but somebody comes in with an opioid use disorder that's pregnant, they automatically get held for 5 days. DCS is called and everything, but we want to dance around somebody that comes in that has problems directly from their drug use. And there's places, so I don't, Richard, I don't know if you guys have these in Norton, but there's recovery navigators that Frontier Health has that will come to the hospital to assess, even if you have a suspicion, just to come speak with them. I just encourage any hospitals to have social workers that are trained in substance use and will talk and answer and ask the hard questions. We're trained to ask the hard questions about suicide, so why not about substance abuse? And even if we are wrong, at least I made the professional decision to at least ask to cover all barriers to prevent that from happening if they were to leave an overdose. So it's just a lot of people are dancing around an issue that's right in their face.
Yeah, and that is, Richard is coming out of the Norton Community Hospital in Southwest Virginia. So it's a smaller hospital. So thinking about some of the resources like we have at Holston Valley or Johnson City Medical Center or some of the even larger hospitals as you start to head in Michael's direction, like Vanderbilt and other hospital systems like that. Resources for a community hospital in Southwest Virginia may be very different, and figuring out what is there and what is accessible. Because I do know you mentioned Frontier, they do have offices in Southwest Virginia, so that may be something to take back to your team, Richard, to follow up on, like what are we doing? I have a funny feeling be a lot of questions asked when Richard gets back to his home hospital.
I'm going to ask, it'd be very interesting to see if our social workers have been exposed to substance use training. If they, if that would be a great place to start if they haven't.
And also I would suggest for the hospital to look at this case as a near miss. If the patient survived, this is a near miss, and they need to evaluate that one and get some, steps placed for the future, prevention. That's something that the hospital in general has to go through when they have the cases of the immediate, admission after the discharge. So.
Do you know, Richard, also, was it a fatal overdose or did she survive it?
No, she did not.
She did not. Yes, Michael.
I was tying us into the previous presentation too. I think when you're dealing with hospital staff, I think dealing with stigma and dealing with beliefs about MAT and its effectiveness, that it's not substituting one drug for the basic beliefs, that's the place I think to start.
Yes. Agreed. Dr. Geller, are you joining us? Do you need to introduce yourself?
Dr. Geller, fellow for a week.
He's counting down still. Any other thoughts or comments for Richard? This is a rather sobering case, Richard.
Sorry about that.
It's all right. It's real, it's real, and it's important that we talk about it and start thinking about, like what's happening here is not what's happening other places. So when you go back to Norton, I know your all's crew tunes in. I hope that you continue to tune in and encourage them to turn on the camera, show their faces, and talk to us, because we need to connect with you guys, because you guys have seen sometimes that little tile that has just all the gobbledygook letters and numbers. That's actually the Norton Community Hospital. It's Richard's residency program that's joining us. So this seems like a really great opportunity to engage more and maybe help some of the system changes that need to happen up there, and connecting you guys to resources and ideas, because that's not okay.
Mm-mm.
Does anybody have a case with a happy ending? Or anything else you guys want to share with us, or other thoughts or comments? We still have about 10 minutes left in today's session.
Well, I will say that the experience we had today with the urine drug screen was interesting, and maybe good thing to share with others. We had one patient that previously came and gave a sample, and the sample of the UDS was evaluated. Specific gravity was 1,000 and no creatinine on it. And the temperature was 90 degrees, and we assumed that this is pretty much hot water and nothing else. And today they came for the follow-up, and the sample was taken exactly the same kind of the picture, specific gravity 1,000. But our smart fellow decided to pour the same urine to another cup with a different serial number. And lo and behold, the urine drug screen shows up. Everything is normal as a result of the switching the cup to the specific gravity of the 1025, and also the temperature the same thing, and creatinine 200. And so it's the same urine, but the cup was faulty. Of course, the urine drug screen comes back positive for methamphetamine and amphetamine and buprenorphine. And so the patient doesn't really refuse to say that he used the methamphetamine, but we were thinking that he is giving us a sample that is water, but it wasn't. So it's our fault that our cup is not showing the right thing. So we always have to question if this test that we are doing is accurate or not before we accuse the patient. In our mind, a few minutes ago, before this revealed by the fellow, was the patient is, trying to mess with us. But we need to get over it because this experience happened right now. And from now on, we question twice our judgment. So
It's a tool, not an absolute.
mm-hmm.
Sometimes your tool doesn't work right. So, yeah, we're supposed to be here to be advocates and helping our patients, not being their adversaries. So
Yes. Live and learn.
we do every day. Some days it's hard. Some days it hurts. The things that we have to learn and what we see in the mirror when we look back and see what we've been doing, where we've been approaching things. But I appreciate everyone being here and continuing and trying and applying themselves and wanting to grow and do better. And Mina, yes, ma'am.
I was just going to make a comment as a social worker that I know that that could have had drastic consequences for someone who had children in the home if that had been done by an untrained or non-clinical person. And we see that happening in our community where people without any medical training are running drug screens. And maybe they wouldn't have thought to do that. And that would have been a horrible thing to happen to one of our moms or dads. It's pretty sobering to think how often that might be happening. Just a thought.
I had a patient that lost the custody of the 4 children as a result of the same thing that some officer did the urine drug screen, and they said that it's positive for the methamphetamine, in which she did not use it, and positive for opioid, but she didn't use it. And then I asked her that did they send it for the confirmation, and she said they put it from one cup to another cup, and they said it's still the same. And they did say that was a confirmation. I said, well, that's not a confirmation. So yeah, that's a devastating, outcome, and she lost the custody of the 4 kids, and she never got it back.
Having non-clinical personnel interpret laboratory tests resulting in a complete divergence of path for those children's lives is kind of really big time, not okay. That's an ace right there. The system just gave those children an adverse childhood experience. The system that's supposed to protect them. Yep.
And we all need the psychotherapy later on with all the trauma that we see is happening to our patients.
Yes. I was just thinking maybe we all need to go on vacation next week. Everybody else is on vacation this week. It's our turn next week, guys. The work we do is hard. It's important. That's why I really appreciate everyone showing up for these echo sessions. We'll be back at it again in 2 weeks, and we'll take a little hiatus, like I mentioned before, and then we'll be back again under the new name of I Am Echo, just to honor the work that we do and all the individuals that it requires to do this work well and appropriate. So any other parting comments or thoughts? I appreciate all of you showing up. Thank you for being here. We'll see you on July 7th. Take care. Bye.
Happy 4th of July.
Yay.